which is given by Professor Bryan Williams from London, and it's about a new study called Pathway.
And just before Bryan Williams begin, I give the name of a discussant of this study. It will be Professor Thierry Gilbert. Oh, no, sorry. I made a mistake. Professor Mancia. This is this afternoon, Professor Mancia.
Okay, good morning. So I'm going to describe in very brief detail the results of the optimal treatment of drug-resistant hypertension. It's one of a series of 3 pathway studies conducted here in the United Kingdom, supported by the British Heart Foundation and the National Institute for Health Research. So the background to this is resistant hypertension has been defined as uncontrolled blood pressure despite treatment with maximum tolerated doses of 3 different blood pressure medications. And according to international guidelines around the world, there's been a convergence that these 3 different medications for most patients now would be a RAS inhibitor, an ACE inhibitor, or an ARB with a calcium channel blocker and a diuretic. Now, the prevalence of uncontrolled blood pressure, despite that treatment, is reported to be about 10% of hypertensive patients who are currently being treated. And that would equate to about 100 million people globally. And these people are at especially high risk of cardiovascular events due to their long-term exposure to high blood pressure and the fact that many of them have other conditions such as diabetes and chronic kidney disease. Now, interestingly, despite nearly 50 years of research in hypertension, the optimal drug treatment for resistant hypertension remains undefined. And recent meta-analyses of available data from very small trials, most of them non-randomized, have suggested that spironolactone, an old drug, 50 years old, an aldosterone receptor antagonist working as a diuretic, may actually be quite an effective treatment. However, there have been no randomized controlled trials directly comparing spironolactone with other blood pressure-lowering drugs to determine whether adding this drug is the most effective treatment for resistant hypertension. So our hypothesis tested in this study is that resistant hypertension is predominantly a sodium-retaining state. These patients still have too much sodium, and this is characterized by a low renin level despite treatment with 3 drugs, A plus C plus D. And that further diuretic therapy with spironolactone will be more effective at achieving blood pressure lowering than alternative treatments such as a beta blocker, bisoprolol, or an alpha blocker, doxazosin, the available options once you've already used the other 3 drugs to treat these patients. So this is the design of Pathway 2. It's actually a very interesting design. Firstly, we screened patients to make sure they were taking the 3 drugs. We measured their blood pressure. They did home blood pressure monitoring to make sure that they didn't have white coat hypertension and they were truly hypertensive. They then were randomized to a cycle. So each patient got each drug in a random cycle for 12 weeks so that we could compare each drug in each patient. And they also got placebo to look at the placebo effect. So 12 weeks treatment cycle, forced titration to a higher dose, and no washout between cycles. And they measured their blood pressure at home after 6 weeks and 12 weeks, and we used the average of those readings to look at the effect of treatment. Now, we used a hierarchical primary endpoint. This is a very powerful statistical technique. Firstly, we were interested in whether spironolactone would be better than placebo as an add-on drug. If that was positive, we could then ask the question, is spironolactone better than the average effect of the other 2 drugs we tested? And if that was positive, is spironolactone better than each of the 2 drugs tested separately? We screened 436 patients, we randomized 335, and we analyzed 315 who had any follow-up during the trial. The mean age was 61, 2/3 were men. Their blood pressures, despite treatment with 3 drugs on home blood pressure, were 147 systolic, 84 diastolic, and their clinic blood pressures remained very elevated at 157/90. About 14% had diabetes. This is the first component of the primary endpoint, which was highly significant. Spironolactone was clearly superior to giving placebo on top of the usual drugs these were taking, with an average blood pressure fall on home average of minus 8.7 millimeters of mercury systolic. So we could then move to the second part. Spironolactone was superior, highly significantly superior to the average of the other two blood pressure drugs that are options for treatment of these patients with resistant hypertension. And then we move to the third component. Spironolactone was very significantly superior to both doxazosin, an alpha blocker, and a beta blocker at reducing blood pressure in resistant hypertension. And in fact, when we look at the achieved blood pressures on these different treatment options, you will see that the average home systolic blood pressure on spironolactone was 134.9, which is just below the target level of 135. In other words, we were controlling a large percentage of these patients with this drug, previously defined as uncontrollable hypertension. This just shows you the primary outcome, placebo, very big effect of spironolactone, and then the effect of the other two active blood pressure lowering drugs, not close to the benefit that we see with spironolactone. If we look at clinic blood pressure changes, we see changes at the bottom panel here of minus 20 millimeters of mercury systolic with spironolactone, convincing result demonstrating really powerful blood pressure lowering effect of this intervention. At the end of the study, despite these patients being deemed by specialists to be uncontrollable for their hypertension, we managed to control almost 60% of these patients on spironolactone therapy. And this was twice as effective as treatment with the other blood pressure lowering drugs. In terms of adverse events and withdrawals, spironolactone was safe in this trial. There was no evidence of any serious adverse events, any adverse event, or withdrawal due to adverse events associated with low-dose spironolactone therapy compared to the other active treatments. So in summary, we demonstrate for the first time that spironolactone, a drug that was first launched 50 years ago as a diuretic for the treatment of hypertension, is overwhelmingly the most effective drug treatment for resistant hypertension. Spironolactone actually controlled blood pressure using very stringent criteria of home blood pressure measurement in almost 60% of these previously uncontrollable patients, and was 3 times more likely than the other drugs to control blood pressure. Spironolactone was well tolerated with no significant adverse effects, with the caveat that you do need to monitor potassium and renal function in these patients over longer-term treatment. And in men, this drug is known to be associated with gynecomastia, some breast tenderness in about 6% of patients with long-term use. But that's a small price to pay for the rest in terms of achieving blood pressure control. Pathway 2 is the first randomized controlled trial to directly compare spironolactone with other active blood pressure lowering treatments in patients with well-characterized hypertension. The result in favor of spironolactone is unequivocal. Spironolactone is the most effective treatment for resistant hypertension, and these results should directly influence guideline treatment for 100 million people globally. Patients should not be defined, in our view, as resistant hypertension going forward unless their blood pressure remains uncontrolled on spironolactone. And this has very significant implications for the design of trials looking at resistant hypertension with other technologies such as device-based therapy. Thank you very much.
Thank you very much, Professor Williams, for this very exciting presentation. Now it's open for questions. Please stay there and we'll get questions.
Bruce Jansen from Cardiology News. Some generic drugs are sort of inexplicably still sort of expensive, others are dirt cheap. Where does spironolactone fit in?
Well, spironolactone, as you know, is a generic drug, and the price will vary in different countries, I suspect, but this should be available as a cheap option for treating these patients. This will not be expensive. And, you know, these patients have very high risk of cardiovascular events, so in cost-effectiveness terms, this will be spectacular.
Hi, I'm Michael Reardon with theheart.org. Over here, Dr. Williams. In the front, sorry.
Oh, right.
It's interesting that you mentioned the device, obviously, with the Simplicity trial. And I was just wondering, in your opinion, is there a tendency possibly for physicians to give up too early in these sort of difficult to treat patients, I've heard a wide range of resistant hypertension, 10% you mentioned, and I've heard even, larger proportions of patients. I just wanted to get a sense of your take on that, whether or not the patients are truly hyper resistant, or if they simply haven't been tried enough.
Let me put it this way. If you look at the 315 patients that we put into this trial, who were randomized through a whole cycle of drugs, at the end of the trial, there were only 15 patients who would have been eligible to randomize into the renal denervation trials on the basis of their blood pressure at the end of our trial. In other words, we managed to control the vast majority of these patients to a level below randomization criteria for renal denervation trials. Now, of course, there will still be a few patients who are resistant, but we suspect many of those with more intensive evaluation, we would often find an underlying cause in those patients. So I think the concept that there are 20, 30% of patients out there with resistant hypertension is wrong. I think with careful evaluation and this kind of treatment approach, a very standardized treatment approach, we can control the majority. One of the residual problems is, of course, that patients don't like taking multiple treatments. And there's no doubt that non-compliance with therapy is a significant issue in this condition. Having said that, we checked compliance in this study very rigorously using urine testing of drugs and also eliminating people who were non-compliant when we measured their blood pressure when they took their drugs in front of us before the trial, and if their blood pressure dropped, we didn't randomize them. So these were very compliant patients, so we could get a very rigorous result. But non-compliance is also an issue. And maybe trying to use the standard treatment in a sort of combined pill approach and then adding on spironolactone if that didn't work would actually improve control generally across the world.
As Crystal Fenn with MedPage Today, perhaps you could comment, or one of the moderators, in terms of generalizability of the findings to other settings and in other countries, perhaps the United States, whether the drugs that you used are the most commonly used ones, or per guidelines, et cetera.
That's a really important question. I mean, one of the challenges in resistant hypertension for many years is that everybody treated the patients as a background treatment in different ways. So patients went into trials on a whole hodgepodge of different drugs. All international guidelines around the world, the European guidelines, the American guidelines, international guidelines, in the last 2 years have really converged and said the optimal therapy at step 3, in other words, if you're on 3 drugs, is a RAS blocker, that's an ACE or an ARB, with a CCB and a diuretic. And that's what we used in this trial. So this is really applicable to routine practice across the whole world now. And the add-on of spironolactone, that's a widely available drug across the world. So it should be easy to deploy this result in changing practice around the world, and we hope it will.
I have a final question for you. It's about the patients that were included. I think there are data that spironolactone might work in certain races, like, I don't know if it's wrong to say races, but let's say the Jamaican population, for example, and also maybe, I saw that the body weight of your patients was pretty high. Can you comment on whether
It's a really interesting question. We had about 2/3 of the patients, the majority of the patients actually were Caucasian, because this was done in Europe. We have some Black African origin patients in the study as well. We haven't had an opportunity to actually break that down and look at whether there were any big differences. If anything, in people of Black African origin, we would expect spironolactone to be even more effective, because sodium retention seems to play a bigger part. And there was a small study, open study without control in the United States supporting that. One thing we did do in the trial, which I haven't reported here, is we did measure plasma renin level. Now, plasma renin is a hormone that is suppressed when there's too much sodium on board in the body. And we found that most of the patients, the majority of the patients, had an abnormally low plasma renin, consistent with our hypothesis that this condition is primarily driven by excess of sodium retention, and therefore predicting that a diuretic would on average be the most effective treatment. And what we actually saw was a really dramatic direct relationship between the effectiveness in spironolactone and low plasma renin. So the lower your plasma renin, therefore the more sodium you had on board, the more powerful spironolactone was at reducing blood pressure. But even taking that into account across the whole spectrum of spironolactone, of plasma renin, on average, spironolactone was usually the best drug. So we've established a hierarchy of treatment for the first time. You start with spironolactone if you have resistant hypertension. If you don't tolerate it or have a problem, the other two drugs we tested are an option, but they're not as effective in the majority of patients.